Your exams don't do flap, neither do we. Straight talk without the sweet talk. All you have to do is listen, read, test, and destroy. Let's start this lecture now.
Let's continue with some special conditions such as the catalase-positive organisms, the pigment producers, and the biofilm-producing bacteria. Catalase-positive organisms are defined by their ability to produce the enzyme catalase, which breaks down hydrogen peroxide, H2O2, into water and molecular oxygen, producing visible oxygen bubbles in laboratory testing. This biochemical property has major clinical consequences that board examiners frequently test in the context of host immune defects. Normally, neutrophils and macrophages generate reactive oxygen species via NADPH oxidase to form hydrogen peroxide, which is then converted by myeloperoxidase into highly microbicidal compounds such as hypochlorous acid. Catalase-positive organisms neutralize hydrogen peroxide before it can be converted into these toxic intermediates, allowing them to survive inside phagocytes. This becomes critically important in patients with chronic granulomatous disease, where NADPH oxidase is deficient and phagocytes cannot generate sufficient reactive oxygen species. These patients rely on hydrogen peroxide produced by microbes themselves to kill pathogens, but catalase-positive organisms destroy their own hydrogen peroxide, leading to recurrent, severe infections. Examiners classically test this concept by asking why certain organisms cause repeated abscesses, pneumonias, lymphadenitis, or osteomyelitis in patients with chronic granulomatous disease, with organisms such as Staphylococcus species, Serratia, Burkholderia cepacia, Nocardia, Aspergillus, Pseudomonas aeruginosa, Escherichia coli, Helicobacter pylori, Listeria monocytogenes, Candida, and Bordetella pertussis being particularly high yield. The unifying feature is not morphology or gram stain but the enzymatic ability to detoxify hydrogen peroxide, which directly explains their enhanced survival in immunocompromised hosts. Pigment-producing bacteria are frequently tested because pigment production often reflects underlying virulence mechanisms and can serve as a diagnostic clue in clinical scenarios. Actinomyces israelii produces yellow sulfur granules, which are not actually sulfur but aggregates of branching filamentous bacteria embedded in inflammatory debris. These granules are typically seen in chronic cervicofacial infections following dental trauma or poor oral hygiene and are a key clue in exam questions describing draining sinus tracts along the jaw. Staphylococcus aureus produces a golden yellow pigment due to carotenoid compounds that also help protect the bacterium from oxidative damage, enhancing virulence and survival against host immune responses. This pigment distinguishes it from coagulase-negative staphylococci and is often tied to aggressive skin and soft tissue infections, abscess formation, and bacteremia. Pseudomonas aeruginosa produces blue-green pigments, including pyocyanin and pyoverdin, which contribute to tissue damage and oxidative stress while also acting as siderophores to acquire iron. Clinically, this organism is associated with characteristic greenish discoloration of wounds or respiratory secretions, especially in hospitalized or immunocompromised patients. Serratia marcescens produces a red pigment due to prodigiosin, a feature that examiners often use to identify it in questions involving hospital-acquired infections, contaminated medical equipment, or infections in intravenous drug users. The pigmentation is not merely cosmetic but reflects metabolic pathways that can enhance survival in environmental and clinical settings. In vivo biofilm-producing bacteria are particularly important because biofilm formation dramatically increases resistance to host defenses and antimicrobial therapy, a concept frequently emphasized in exam questions involving persistent or device-related infections. Staphylococcus epidermidis is a classic example, producing biofilms on catheters, prosthetic joints, and heart valves. Its ability to adhere to synthetic materials and secrete extracellular polysaccharides allows it to evade immune clearance and antibiotics, explaining why infections often require removal of the infected device rather than antibiotic therapy alone. Viridans streptococci, particularly Streptococcus mutans and Streptococcus sanguinis, form biofilms on tooth surfaces, creating dental plaque through dextrin production from sucrose. This same adherence property allows these organisms to colonize damaged heart valves, leading to subacute infective endocarditis, a scenario examiners commonly test following dental procedures in patients with pre-existing valvular disease. Pseudomonas aeruginosa also forms robust biofilms, especially in the respiratory tracts of patients with cystic fibrosis, where thick mucus and impaired clearance provide an ideal environment. Biofilm formation explains its persistence despite antibiotics and its role in ventilator-associated pneumonia and contact lens-related keratitis. Non-typable, unencapsulated Haemophilus influenza produces biofilms in the middle ear, contributing to recurrent otitis media, particularly in children. The absence of a capsule differentiates it from invasive encapsulated strains but enhances its ability to adhere to mucosal surfaces and persist locally. Across all these organisms, the shared exam-relevant concept is that biofilms protect bacteria from immune cells and antibiotics, leading to chronic, recurrent, or device-associated infections that often require mechanical removal or prolonged therapy rather than standard treatment alone.